So as we have discussed, hyponatremia, you all know the normal levels of hyponatremia, normal levels of sodium is 135 to 145 milliequivalents per liter. So we call it as hyponatremia if it is defined as a serum sodium less than 135. Most of the times it occurs in hospitalized patients. As I said earlier, it is primarily a disorder of water balance. So ADH, antidiuretic hormone, has a primary role in the pathophysiology of hyponatremia. So as you all know, ADH is released and there will be two problems. One is the central diabetes insipidus, because there will be a problem with the release of ADH, as well as a diabetes insipidus, that is nephrogenic diabetes insipidus, which is due to the ineffective functioning of the ADH in the kidney. Okay, so ADH has a primary role in the pathophysiology of hyponatremia because ADH is the one which actually helps in your water balance. Am I clear? Can you all hear?
Yeah, doctor,
Hello?
please go ahead.
Yeah. Okay. So as we all know, if there is a problem with your blood pressure, I mean, like if your blood pressures are high or low, whether your circulating volume is reducing, so there are major changes that occur in the kidney. Okay, and many of the hormones are released. That is your renin, which converts the angiotensin 1 to angiotensin 2 in the presence of angiotensin converting enzyme, which leads to increasing the effective circulating volume, as well as it helps in the sodium and water retention. So that is the way how the sodium is conserved inside the body. Okay, so this is the antidiuretic hormone where the ADH released from the posterior pituitary, which causes the direct systemic vasoconstriction, or the second problem, as we have discussed, it will help in the water reabsorption in the distal tubules and the collecting ducts. So these are the basic classifications of hyponatremia. Less than 135 is hyponatremia, moderate is 125 to 129, and severe is less than 125. And we call it as per US guidelines, severe is less than 125, we call it as severe hyponatremia. As per European guidelines, we call it as profound hyponatremia. So whatever the terminology, we can follow whatever we want. So symptoms, the problem with the limitations is symptoms does not always correlate with the degree of hyponatremia, because the patient who is chronic hyponatremic may not be able to show all these symptoms. So we need to know what is acute, what is chronic. So we call it as an acute hyponatremia if the time of development is less than 48 hours. We say it as chronic hyponatremia if it is more than 48 hours. Because what happens is, as we all know, in the blood, there will be tight endothelial junctions. So what happens is the sodium can go in and come out very easily. Along the water, there will be a distribution of sodium. But what happens in the brain, the endothelial junctions are too tight and they don't have any clefts. So as a result, the water alone can go in and come out, but the sodium cannot move in and out. So that's the reason why patient develops cerebral edema early in the 48 hours. But once it becomes chronic, the osmolarity usually slowly gets settled in and the patient may not have that much of symptoms. Symptomatic versus asymptomatic, that is, presence of symptoms and absence of symptoms. Hypotonic, isotonic, or hypotonic. So for this, we need to know the serum osmolarity. So as you all know, serum osmolarity is the number of osmoles. So hypotonic is presence of the less sodium. Hypertonic is presence of the more sodium. So also sometimes there will be ineffective osmoles like urine or alcohol also may be present. And hypovolemic also, whenever you are seeing a hyponatremic patient, you first need to know the fluid balance. So you always need to know the volume status of the patient. So you need to see whether it is hypovolemic, euvolemic, or hypervolemic. Depending upon this, our treatment for hyponatremia goes. Okay, next. Manifestations always develops at sodium 125 to 130 when acute and 120 to 125 when chronic. So usually if it is 125 to 130, it will be fatigue, headache, nausea and vomiting. And when it is less than 120, most of the times it will be confusion, drowsiness, seizures and coma. So you can remember it as a mnemonic fried salt, FRIED salt. So that is fatigue, restlessness, insomnia, and excessive irritability, drowsiness, confusion, seizures, and all these. Okay, lethargy or tremors, all these. Okay, so you can remember it as fried salt. And presence of and severity of symptoms are related to the severity of derangement, as we all know, and the speed at which the derangement developed. So this is what I said earlier. Always your sodium depends upon your sodium and potassium channel, sodium potassium ATPase, as you all know. As I told earlier, because the brain junctions are too tight. Only water goes in and comes out. So as a result, there will be formation of cerebral edema. So always remember, if it is a hyponatremia, because of the more water in the brain swells. So as a result, there will be increase in the intracranial pressure. So patient can develop cerebral edema. If it is a hypernatremia, there will be loss of more water. As a result, the brain shrinks, and as a result, there will be chances of patient developing hemorrhage. So always, if it is hyponatremia, it is cerebral edema, and if it is hypernatremia, it may be a CNS bleed.